Thank you.
Thank you.
Thank you.
Oh, wait, I'm sorry, Senator Savino had a question. Excuse me.
Don't run away. Thank you. I just want to, on the first page of your testimony here, you sat here and listened to Commissioner Delaney's testimony, didn't you?
Yes.
And you heard us, numerous members, ask her the same question over and over. Did she have a sense of how much money this minimum wage increase could potentially cost the providers?
Yes,
and you heard her say over and over that they hadn't really done an analysis and they did not know. So you've done your own analysis, fairly simple. You know how many employees you have, you know how much money it would cost you, and actually you have a pretty good graph in here in case people want to read it. Did they ever at any point ask your agency what it would cost?
Yes, we've been meeting with the Department of Budget regularly. They have our numbers, $270 million.
Not to interrupt, but prior to the announcement of the $15, or was it subsequent to it?
We've been working on this probably since April. Certainly prior to the budget coming out, we were trying to make the case for it to be funded in the budget. So we worked out the numbers, the $270 million in this budget, the $1.7 billion in the out year, 2021. And in our conversations with DOB, they have acknowledged that our numbers seem to be pretty realistic. They haven't been critical of our methodology, so I think we're in the same probably neighborhood as they are.
Were you at all surprised when the budget was put out in January and there was no acknowledgement in the budget for the increase in the minimum wage for the nonprofit sector?
We're extraordinarily disappointed, and I can say that the parents that make up the governance of my organization are downright angry.
It's incredibly diplomatic of you. It would seem to be somewhat frustrating if you had spent months having these discussions and analyzing and providing the data, and to see that it wasn't reflective in the budget itself. And I don't mean to put you on the spot, but we've been told from the beginning that they hadn't analyzed it, they hadn't thought about it. Well, obviously they have, and they've made a decision not to put it in there, so I'm not sure whether they want us to put it in, or they're assuming that your agencies are going to absorb this. But based on the information you've given us, and based on your written testimony here, and the fact that you have, as you said, 28,500 employees, of which 77% of them are direct support professionals who earn at most $11 an hour in the entry level, and I think you said 15?
Their average wage is roughly between 11.5 and 13.5 when you look at different parts of the state. Obviously, downstate wages are a little higher.
And their highest point?
At their average. So some people might make 15, 16, but one of the things that's a factor for us is if we move our new employees up to, say 12 or 13 or 14, the people that have been with us for 6 or 7 or 8 years, they can't stay there. We have to keep that career ladder. They've gone back to school, they've gotten certifications, they've gotten education. So they're going to end up, if they can't end up at the entry level, we have to bump them a commensurate amount in career ladders. So really, it's shifting that whole workforce down a continuum, not just the people on their first day.
What is the annual starting salary for a direct support professional?
Between $9.5 and $11.5 an hour.
Do you know what the annual amount is?
Oh,
if you don't, that's okay.
I had done the numbers, but it's about 20,000 or so.
And you said you have a high vacancy rate.
Yes.
When people leave, do they go to the public sector? Do they go to the state agency or the county agencies? Any of our chapters that has is in the community where there is a state-operated program. It's okay.
Excuse me, Senator.
Don't joke.
Any of our chapters that's in a community where there's a state-operated program is used to having our staff get training with us and then leave as soon as there's an opening, because the state-operating programs all start at well above $15 an hour. My chapters cut out the newspaper ads and send me these that say that the state salaries are starting at $15, $16 an hour.
That is exactly the point I was trying to get to. Many years ago, the difference between the nonprofit sector and the public sector, the difference in salaries could be somewhere between $3,000 and $4,000 a year. That gap has grown considerably over the past 20 years, so it speaks to how we value human services in our nonprofit world when we are requiring more and more of those services to be done by the nonprofit world. Thank you for your testimony.
Thank you. The COLA issue has come up. In addition to no money for the minimum wage, the COLA works out to about 3 cents an hour. So multiply that out by a work year of about 2,000 hours, which is the number we use. You're talking about roughly $50-something before taxes. So what, $35? So you can take a family of 4 out for a fast food dinner, but you can't take them to the movies because you couldn't cover the price of the tickets today. And so It's tantamount to zero. Our direct support professionals did get 4% last year, but that was after a 6-year freeze. So if you take 4%, average it out over 8 years, we're losing ground even before we talk about the minimum wage.
Thank you.
Senator.
Thank you.
Mental Health Association of New York State, Glenn Lieberman, CEO. After that will be Wendy Birch and Irene Turksky. You look familiar.
Good afternoon. Can you hear me?
Afternoon.
Yeah.
Afternoon. My name is Glenn Liebman. I'm the CEO of the Mental Health Association in New York State. Our organization is comprised of 50, we're involved in 50 counties around New York State. Most of our members provide community-based mental health services, but we also provide a lot of education, advocacy in the community, very mission-driven in terms of advocacy, education, support, and training. And I'd like to start off by really giving you a great thank you. Last year I came and I testified about the importance of prevention and anti-stigma efforts. And I talked specifically about a mental health tax checkoff and how important that was to the community. And I have to thank Assemblywoman Gunther for her leadership, Senator Ord for his leadership, and Senator Carlucci for his leadership as well in making that happen. It was so incredibly significant. To some people, it's a box on an income tax form. Excuse me, I get choked up about it. But to us, it is so much more. It is saying that mental health public awareness is as significant as breast cancer, as Alzheimer's, as any other biological illness. So that was an incredibly significant message, and hopefully there'll be money made from it that'll go into public awareness. So it really was a significant victory, and frankly, it's landmark, and there are 5 states that have already contacted me about doing it in their states as well. So thank you all very much for your leadership on that. So that said, we're going to build on that momentum as well. We're working very closely with our chairs and the other members of the committee around issues around school-based mental health. That was brought up today, and that was great. We want to create legislation, it's already out there, around forcing, and people don't like the word mandate, and people walk away from the word mandate, but the reality is this would be a mandate to create mental health education in schools. We think that sometimes you have to just address what it is. Mental health education in schools are incredibly significant. When you have 25% of kids having a mental health related issue, when you can go from kindergarten through your senior year of high school and never hear words like depression and anxiety and suicide prevention, and yet it's so pervasive among children. So we really have to have that happen. But I'm here today, that's our #1 legislative item, and certainly at the Mental Health Association, because we're involved in the public mental health system, we're also involved in the public at large. We carry a lot of issues. But the one issue I'm really going to focus on today, which Harvey referenced as well, is the investment in community mental health. So right now in New York State, the public mental health system has about 800,000 people in it. Yet half of that funding, and this has been this way for many years, is still driven by a few thousand people in the hospital system. The funding in the community is just an incredibly small percentage. So you're basically saying you have 800,000 people in the public mental health system, 750 of which are dealing with about the same amount of funding as 50,000 people are dealing with. So we're dealing with a very underfunded system. And we know it's not out of the ordinary for someone discharged from a psychiatric or public hospital to have to wait months for follow-up. The fault doesn't lie with providers. The fault lies with the system that is underfunded and overstretched. And people before me have made this argument, we heard it very articulately from the other folks who presented, that what have we gotten in the last 7 years in terms of the public mental health system? Well, thankfully, because of the legislature, we got a 2% increase for direct care workers last year. And this year, as we know, we're talking about the 0.2% increase. Now, there have been other funding streams that have come to the community mental health system, notably reinvestment among others. But the bottom line is we're looking for a real investment in mental health this year. On top of, and believe me, we are foursquare behind the minimum wage increase, and we couldn't, the passion that Steve carried, we totally agree with that 100% in mental health. But we also believe that we should have a $90 million investment in mental health this year. We have heard about all the large projects that are out there, and, you know, we applaud the governor for his work on homelessness and putting money out there for homelessness. We think it's an essential issue, and we like to see that happen. But we're certainly hearing about all kinds of other things that are out there, and Harvey referenced DSRIP and the $8 billion that are in DSRIP. And yet we are frustrated because we're not seeing more funding in our community. We, you know, for services, for administration, for workforce retention. And, you know, their bottom line is that, you know, we have not had a COLA of any kind outside of, as I referenced, for 7 years. 7 years of a system of care that continues, the infrastructure continues to grow, the needs of people continue to grow. Senator Savino, you made a great point about the fact that, you know, we have a whole sector in the, you know, within the state-operated programs that are taking a lot of the folks who are working in direct care and working for our agencies. So there's a great disconnect there. And as Harvey said, we're not asking for you to, you know, it'd be great if, believe me, if, you know, negotiating with the governor came up with $90 million, that would be fantastic. But there are 3 funding streams here, as Assemblywoman Gunther pointed out and Harvey pointed out. You know, early on, the reinvestment, there's over $5.5 million this year that was promised to the community that hasn't come to fruition. There was the $20 million that has gone from Medicaid to BIP. There's $44 million that's gone from Medicaid to bonded capital resources for supported housing. Why is that money being used as a substitute? Why do we have to do that? Why are we not taking that money and investing in the community? That's exactly what we're calling for, a true investment in the mental health community. And, you know, there are a lot of other things we're working on as too. Clearly, housing, you're going to hear from our colleagues at ACL make a very articulate case about the need for more housing in the community, medication access, and a series of so many other issues that are so important to us. But those, you know, given the time frame, I wanted to sort of focus on that.
Questions?
Yes, Senator Krueger.
Thank you. Thank you for your testimony.
Sure.
In your testimony, you actually recommend that the adult homes become included in oversight by the Justice Center. So there have been a number of people here who have raised concerns about the Justice Center, and in fact, they weren't able to testify today. But you actually are testifying that it would be of value to have the adult home community, I guess, under 80 beds, included in oversight by the Justice Center.
Well, you know, that's a good question. We advocated for that because there was such a bifurcation in the system. Everywhere else in the public system of care is under the aegis of the Justice Center. And yet it seems just like, I have no idea why this, I have my theories, but the bottom line is, it's like over 80 beds in adult homes are covered by the Justice Center. Everywhere else in the system is covered by the Justice Center. Why are under 80 beds in adult homes not covered by the Justice Center? It's a matter of equality, and they should be, you know, under the same sort of jurisdiction, the Justice Center, as every other entity.
Right. Thank you very much.
Sure.
Thank you.
The next.
I just really quickly, I just want to make sure that we understand that right now you're asking for a $90 million investment, that you're asking for a COLA for all those direct support professionals that have worked so long, over 7 years, with at this point, over 7 years, 4% increase, and the cost of living has gone up dramatically. And I think that as a community with a large budget, that we should work together to make this come to fruition.
Thank you very much.
Next presenter is Wendy Birch, Executive Director, National Alliance on Mental Health, followed by John Coppola, Alcoholism and Substance Abuse Providers in New York State. They're on deck. Also, I believe Irene Tursky is with Wendy today.
Actually, Irene's with me, so.
Go ahead.
Good afternoon. My name is Wendy Birch. I am the Executive Director for the National Alliance on Mental Illness for New York State. With me today is Irene Tursky, our Government Affairs and Housing Committee Chair, and the family member of a caregiver of a loved one with a severe mental illness. Irene's family story speaks to why our legislative leaders must take action for the approximately 673,000 adult New Yorkers living with a serious mental illness. Our written testimony focuses on several areas, including the necessity for paid family leave, reinstatement of prescriber prevails, additional funding allocated to crisis intervention training, and sustainment of New York's 2 state-of-the-art research institutions. We would like to take this opportunity to speak more in depth on one of NAMI New York State's top priorities, which is housing. The systems which deliver mental health care in New York State are currently going through a radical overhaul at a very rapid pace. The executive budget proposes the reduction of 225 psychiatric beds in fiscal year 2017. NAMI New York State is only able to support some of these reductions if the necessary safety nets are put in place to ensure that these people are relocated to a setting which will properly address their specialized needs and to ensure that families are educated and have the opportunity to participate in a loved one's recovery. These requirements can only be achieved through having housing and community services that are properly funded and have the full capacity to provide the specialized care this population needs.
I am an unpaid mental illness advocate with a sister who has a serious mental illness. The only way she has been able to live in the community is due to a community residence that has the necessary staff and support services to keep her healthy. The availability of a safe and appropriate place for our loved ones to live and advance their recovery remains the main priority for NAMI, as well as many of our not-for-profit colleagues who provide vital housing services. NAMI applauds the executive budget for not targeting the closure of any state-funded psychiatric hospitals in fiscal year 2017, which provide services for those with the most serious and persistent types of mental illness. But as Wendy detailed, it does propose the reduction of 225 psychiatric beds. These people must have the necessary staff and support services, which are provided in a community residence type of housing, to teach them how and when to take medications, and in the most serious cases, basic needs such as personal hygiene and how to feed themselves. People are being sent to nursing facilities where there is no chance for them to learn how to advance their skills in order to have a chance at a meaningful and independent life. NAMI New York State is only able to support any bed reductions if the stipulation the budget calls for are put in place in advance for these people. Many of the housing providers who would be responsible for taking in this population currently do not have the capability to meet the myriad of challenges these people present. This is such a strong point that I cannot stress the importance of heeding their pleas. As of last month, housing providers are telling the Office of Mental Health, NAMI, and anyone else who will listen that they do not have the resources to take care of the people that are being released from the psychiatric hospital bed closures. History has shown us this is a recipe for disaster, and it's at the expense of our most vulnerable human beings, those with serious mental illness, who depend on others to take care of them in their compromised state of mind. Removing someone with serious and persistent mental illness from a highly supported setting and placing them in a facility with anything less will have disastrous results, including homelessness, entry into the criminal justice system, overdependence on emergency rooms, and in the most tragic situations, death from either suicide or the misuse of medication. As Commissioner Sullivan said today, we have to focus first on suitable housing before people with mental illness will engage in any programs or services in the community. We urge you to make sure that the transition from psychiatric hospitals is done as appropriately and responsibly as possible. I struggle every day to get my sister access to health care and services. I see many of the programs and supports that my sister once enjoyed and thrived in consolidated or eliminated. I ask myself where these community reinvestments are being allocated. At Buffalo Psychiatric Center, we just found out that the Office of Mental Health is already in the process of closing their only geriatric clinic. So now our elderly with mental illness will also be sent to the Buffalo Psychiatric Facility along with the children. When you heard Commissioner Sullivan today talk of hiring additional security for Buffalo Psychiatric Center, we need to question, why are we sending our children and elderly there? As Senator Kennedy said today, if it ain't broke, why fix it? Thank you for your time today and listening to the pleas of NAMI New York State and the families we represent.
Thank you.
Thank you.
Appreciate you.
Next is John Coppola, Alcoholism and Substance Abuse Providers in New York State, and after that, Stephanie McLean Beefley, Save Our Western New York Children's Psychiatric Center.
Thank you for letting me pour my water before you started the clock. Good afternoon.
Good afternoon.
I want to start by simply calling attention to the magnitude of the heroin and prescription opiate epidemic in New York State. When Senator Martins asked the commissioner if she considered it to be a state of emergency, and then she talked about doing what she could within the parameters that she was given and within the budget that she was given, I think it begs the question, and for each of you and for your colleagues, at what point would the magnitude of your response be suitable for the magnitude of the issue that's facing families and individuals in your districts? When you think about the magnitude of the loss because of the death of children and spouses to addiction, and think about the magnitude in those families, what about the magnitude of the folks who said, I have a problem, I want help, and we're told we have no room, we have no beds, we have nobody who can take you into our program this week? We called ahead of time and started surveying programs, asking what waiting lists are. There are waiting lists. So again, what would the magnitude of the response that you would be satisfied with that would seek in this budget to address the needs of those folks who've asked for help and have been told it's not available here in this particular region of the state? I'd like to point to a couple of key recommendations. First, let's talk about prevention, and there were a lot of questions for the Commissioner about prevention. It is completely and totally unacceptable that we would look at a $2 million ad that you did as one-time spending, right? And again, so let's just go along with that hypothesis for a moment. I would hope that you would say, no, it wasn't one time. We're going to put that money back in, A, and B, we're going to look at what is the correct magnitude of our response as it relates to prevention in this budget. Where would we feel comfortable with this budget, right? And so what do we have to do to make sure that we've got adequate resources in our schools and in our communities? And I would suggest, Senator Kruger, to your question about pregnant women and babies being born addicted, the only appropriate response, in my view, in terms of an acceptable magnitude, would be that we think about that question and we make sure that the infrastructure of our prevention approach includes, in every hospital in this state, some ability to assess whether women are addicted and pregnant, A, and B, what do they need so that we can deliver healthy babies and have moms who get into recovery early on. That is the only acceptable response as it relates to the magnitude of this issue. And I would point out that I was invited to Washington several years ago, not last week, but several years ago, when Syracuse was identified as like sort of the epicenter for that question, right? The number of people being born addicted, the number of babies being born addicted in Syracuse was higher than almost any other place in the country at the time, right? So again, I would submit that we ask ourselves a question about prevention as it relates to magnitude of response. On the treatment side, so we're recommending $20 million to be added to the prevention budget, specifically to hire approximately 300 additional prevention folks and to disperse them across the state across a spectrum of prevention strategies. On the treatment end, we're recommending additional funding to eliminate waiting lists and to really address the need for additional treatment beds. 135 beds being available today if we went to the OASIS website. Let's say, okay, what if it was an adolescent that needed a bed? Is one of those 135 beds for an adolescent? What if it's a transgendered individual who's looking for a culturally competent program where they can get treatment for their addiction? Do we have such a program anywhere in the state? If so, where is it? And do they happen to have a bed? Does that program happen to have a bed? So again, I think there's a need to make sure that in each region of the state, treatment services are accessible. One thing I'd have to say, and I think the Commissioner undersold herself in her testimony, she has made a remarkable pitcher of lemonade out of lemons as it relates to the limitations that she's been given. I mean, she has added a considerable number of treatment slots and medication-assisted treatment across the state like we've never seen before. And so there's lots of folks who no longer have to drive 3 or 4 hours every single day one way to get their dose of medication and then drive 3 or 4 hours back. So she is really to be commended for adding significant slots in medication-assisted treatment. Recovery community centers, when we start talking about clubhouses and recovery centers, 6 is a ridiculously low number when we have 3 or 4 currently existing. We should really work to make sure that we have a robust number and access. There are a couple pools of funding in the budget. There's $195 million for healthcare facility transformation. We think that 25% of that should be specifically committed to behavioral health organizations, mental health and addiction services. The DSHRP program, which is supposed to be reducing unnecessary hospitalizations, has promised significant resources to the behavioral health community with substance use disorders and mental illness, and those dollars are not flowing. So I would suggest that we really look at what are the opportunities existing in the budget where programs have been designed to rely heavily on mental health and substance use disorder service providers. They're designed to drive people into those systems instead of into ER and emergency departments. And those programs have yet to become what they're supposed to be, right? And it feels like a case of the emperor's new clothes. We've got to really, I think, watch out for that. And then finally, I'd like to close with just a sort of an emphasis on workforce. The deferral of the cost of living increase over the course of the last 5 years, there's approximately $500 million that the human service system did not receive because in our budget process we deferred the COLA to the next year, and then we deferred it to the next year, and then we deferred it to the next year. If you go back to the state budget and look at how much has been deferred over that period of time, it's over $500 million that our folks did not receive. And again, just to sort of do another variation on the math of this, I mean, it's ridiculously embarrassing to think about the possibility of asking somebody to come into your office who's making $35,000 a year to tell them that they've just been given a $70 increase before taxes. So that's not acceptable. I think what we really have to do is look at a really substantial cost of living increase across the board for the human service sector. Thank you.
Thank you, and we'll look at your testimony too. So thank you very much for being here today. There's one question from Senator. Oh, I'm sorry. The Assembly's first. So.
Oh, excuse me.
Assemblywoman Rosenthal. Thank you.
Thank you. Hi. First, I'd like to thank you for your extraordinary work for many years and enlightening me about the challenges in this field. I'd just like to ask you, and I don't know if you covered it because I was out, I apologize. We see that now Narcan can work miracles, bring people back from almost the edge. So they go to an emergency room, they get a Narcan, they're back. What happens to them then? What I hear is mostly they're released. Most often they go back to using. So can you describe what you think would be the ideal way to handle a situation where someone's either just gotten Narcan or, is overdosed, brought back, then what should happen?
Great. So I think it starts with Narcan itself, and I think the Senate and the Assembly and Governor's Office are doing the right thing by doing everything you can to make Narcan as accessible as possible and to have as many people trained in how to use it as possible. I think then we have to say, okay, so now that we have this person, and again, if we think about somebody who's acutely depressed and suicidal, right, and does something that's harmful to themselves, we have some ability to engage them and to try to have them seek services. We're concerned about their overall health. I would submit to you that if somebody has just overdosed, they're a danger to themselves, and I would suggest that at an absolute minimum, we should do everything we can to try to help that person get connected with treatment. To the extent that many people are not interested in treatment, right, they consider themselves to have had maybe a lucky day that they were saved and they're going to be fine, and they don't want to have treatment imposed on them, at an absolute minimum, it would seem to me that we should require dissemination of information, to those folks. When the commissioner talked about a peer approach, that if they're in an emergency department in a hospital, to have peers deployed is a fantastic idea. I would say, though, that the amount of resources that OASIS has been given to do that, going back to the comment I made to Senator Kruger's recommendation, that should be available across the board. And so it should be a comprehensive approach, again, where the magnitude of the response is comparable to the magnitude of the problem. And then I would also say that it's incredibly important that we make sure that all of our treatment programs are educating clients as they come in about the dangers of relapse, that when you relapse as somebody who's addicted to an opiate, you're at extraordinarily high risk. So many overdoses happen after people have had a medical intervention or an intervention from a treatment program and go back to the community. So I think there's a lot we have to do to make sure that all of the systems are appropriately educated and that the person who's suffering from the addiction is given the appropriate opportunity to engage in services.
It doesn't appear that with the funding in this budget that will be something we can accomplish in the near future, unless it's really ramped up.
Yeah, I think that's an understatement. I mean, I think, or an overstatement. I think there's really, to say that we're going to have some peer navigators in 3 or 4 hospitals across the state is a good idea for those 3 or 4 communities, but it's something that really needs a substantial investment. I think you're correct.
Any question?
Yes.
Senator Kruger.
Hi, John. You always enlighten me every year. So your discussion about the issues for addicts with methadone living in a rural environment where they might have to drive 3 or 4 hours each way to get their daily methadone. And my immediate response in my head was, oh, well, I'd be back on drugs in 2 seconds flat. Who's going to drive 6 to 8 hours a day to get their alternative? But I also looked up Suboxone. I'm saying it wrong. But you can do 1-month prescriptions. So I guess 2 questions. Why is there such slow take-up to use Suboxone by doctors and clinics? And wouldn't it be a much more efficient option, at least in the rural communities, where instead of having to get somewhere every day, you would have to get to a provider once a month?